Laparoscopic nephrectomy. So let's restart. So hi guys, so I welcome you to this particular session. Today, what we are going to talk about, we are basically going to talk about the laparoscopic nephrectomy. Okay. Now, all of you understand what is a nephrectomy. Nephrectomy is basically the removal of the kidney from the body. Okay. Now, why would you want to remove a kidney from the body? Let's say if at all there is some non-functioning kidney. Let's say there is a stag-on calculus, which has led to the hydronephrosis, which has led to the poorly functioning kidney. That is, can be one of the reasons. Then there can be, let's say, some tumor on the kidney. Because of that, you might be wanting to remove that particular kidney. Or let's say there is a donor nephrectomy. Let's say somebody wants to donate a kidney to some other person. You have a choice to kind of remove the kidney and give it to the other person, right? Now, all these are the indications of performing a nephrectomy. Now, whenever you want to perform a nephrectomy, either you can perform by the open route or you can perform by the laparoscopic route. Okay. Now, what we're going to talk about is the laparoscopic nephrectomy. So, what are the different surgical approaches which we have for the laparoscopic nephrectomy? Either there can be a transperitoneal, there can be retroperitoneal, or there can be hand assisted. Now, what is this transperitoneal? You are basically entering into the peritoneal cavity, and through the peritoneal cavity, you're removing the kidney. That is what is a transperitoneal approach. What about the retroperitoneal approach? You are basically going behind the peritoneum. You're not entering inside the peritoneal cavity. Our kidney is a retroperitoneal organ, right? So yes, you can kind of remove the kidney via the retroperitoneum. And the other one is a hand assisted. So here, most of the things are done by the laparoscopic route, but there is a hand port which you can put in order to kind of mobilize the kidney, in order to kind of get the control of the what you call as the vessels and all those particular stuff. Okay, so this is a very, very basic difference. This is more elaborate difference between them. In the transperitoneum, there is a small incision and it gives advantage for the two-car placement. That's all fine. Uh, Affords optimal working space. So the benefit of the transperitoneum over the retroperitoneum is that in the transperitoneal approach, your working space is good because you can create a pneumoperitoneum and abdomen gets descended. And inside the peritoneal cavity, there is a like a CO2, which is basically filled up. And yes, you have a good amount of space in order to operate in the transperitoneal approach. In the retroperitoneal approach, first of all, what do you think of? Like, what will be the consideration in order to do a retroperitoneal surgery? Let's assume that there is a patient who has undergone a multiple intra-abdominal procedures. Okay, so if at all, let's say there is a limited working space, okay, resulting in the difficulty in kind of orientation or the trocar spacing or the organ entrapment. So let's say if at all somebody has undergone 4, 5 intra-abdominal surgeries, you expect a lot of adhesions. So it will not be an easy surgery if you're trying to do it through the transperitoneal approach. In such patients, you prefer a retroperitoneal approach. Okay, understood? Right. Now, the disadvantage of a retroperitoneal approach is the space. We do not have a good amount of space in order to operate if at all you're performing a retroperitoneal surgery. Okay, so it's preferred in the patients with the history of the multiple abdominal procedures. That's fine, but it doesn't kind of give you good amount of space to operate. Okay. And let's assume that there is a tumor which is basically present on the posterior surface of the kidney. Okay. Then again, what you should prefer is a retroperitoneal approach. Okay. Also preferred in the patients with an abnormality on the posterior surface of the kidney. What you should prefer is a retroperitoneal approach. Okay. Understood? Right. Now, what about the hand assisted? So it is basically a bridge between the laparoscopic and the open surgery. That's fine. And yeah, permits kind of tactile feedback and also the hand to assist the dissection, all those particular stuff is there. Okay. Now, coming to the patient evaluation and the preparation. So, what do you do? Okay. So, what you need to understand is that uh, first is the port placement. Okay, so port placement is you usually place around 3 or 4 kind of ports. Okay, now let's kind of walk you through it one by one. Let's assume that I am a patient and I need a laparoscopic nephrectomy, let's say tomorrow. What will you advise me beforehand? So this is like inside the OT, that's fine. But beforehand, what you will advise me, or let's say if at all I'm admitted with you, what are you going to kind of do to me? First is bowel preparation. So we give the in our institute, we basically give an enema. Why do we give an enema? So that the bowel is basically becoming empty, so that it is easier for us to kind of mobilize the colon. okay, because we want to kind of reach to the kidney. So for the easy mobilization of the colon, what you do is we basically give a good bowel trip so that the colon is basically getting empty. We place a Foley catheter and we get an IV access. Why do we do that? Because we obviously want the bladder not to get over distended because the patient will be under general anesthesia, obviously. So you put a Foley catheter that is obviously given. And obviously you have to get an IV access so that the anesthetist will be able to give drugs, and you will be able to give fluids, all those particular stuff. You give the prophylactic antibiotic. Yes, you give. When do you give that? 1 hour before the surgery or at the time of induction of anesthesia. Okay, so you give a prophylactic antibiotic to these particular patients 1 hour before the procedure, or maybe at the time of induction of anesthesia. What do you prefer? Obviously, for a laparoscopic or like a nephrectomy, the anesthesia which you prefer is a general anesthesia, and you have to place the patients in the lateral decubitus position. So, for example, let's say you want to operate on my right side kidney. My right side has to be up. If you want to operate on my left side kidney, my left side has to be up. Okay. So yeah, the affected side has to be up and the kidney kind of rest is raised. Okay, that's fine. Kidney bridge. That's controversial. Few people apply it, few people don't apply it. That's fine. You understand what's a kidney bridge? It's a part of the table which basically takes that particular part up. The reason why you should not apply causes pain in certain patients in the post-operative period. But if you apply, then the kidney is kind of opened up and you find it easier to kind of reach to the kidney. That's fine. It's completely surgeon preference. Nowadays, we have started to not apply it while doing an effect. Okay, so that is what is a patient preparation, preoperative preparation. Okay, then what comes is the port placement. So inside the operation theater, when you have taken the patient, once you have given the position to the patient, the decubitus position has been given, what you have to do is a port placement. Okay, so whatever the way you want, you can either use an open or which is a Hudson's method, or what you can do is a Veris, or if you want like what do you call as an optical trocar method, that is also what you can do. So these are the three ways in which you can create a pneumoperitoneum. Pneumoperitoneum is created by the Veris needle, okay, which is most commonly followed, or a Hudson's cannula, Hudson's technique, if at all it's an open method. It's safer if at all any intra-abdominal surgery has taken place earlier. Okay, that's fine. Now, typically 3 or 4 ports are placed. At least 3 ports are usually needed. Okay, so first is basically the camera port, which is near the umbilicus. So umbilicus or the lateral to the rectus sheath. We have a rectus muscle. We have to place this particular port lateral to the rectus sheath. Okay, umbilicus, like it's near the umbilicus. Working port. One is subcostal and one in the iliac fossa. So I'll just show to you these are the port placements. Okay, so this is an umbilical port. Here, the rectus sheath, we place it lateral to the rectus sheath. Then what you have a subcostal port at the mid-clavicular line. You can place it just below the kind of a costal margin. We leave around a couple of fingers gap between the costal margin, and then we kind of place it in the mid-clavicular line. And the next one is basically placed on the spino-umbilical line. So this is an umbilicus. This is a kind of anterosuperior spine. At the midpoint of it, usually you kind of place it. Okay. Now, this is just a rough understanding about the port placement. As you become more experienced with the laparoscopic surgery, you will place these particular ports in a better manner. Especially in the obese patients, you have to shift these particular ports a bit more lateral. Okay, so that's what you have to do. That's fine. This is on the left side if you want to kind of do a left nephrectomy. On the right side, this additional port is needed in order to retract the liver. Okay, in order to retract the liver, this additional port is kind of usually. Okay, right. Now, support placement, that's done. Okay, right. Now the first step, like once you have created the pneumoperitoneum, now you have placed the ports and everything. The first step of the laparoscopic nephrectomy is you have to mobilize the colon because kidney is basically present behind the colon, right? And you're going through a transperitoneal approach. So first you have to kind of mobilize the colon. How do you mobilize the colon? The principles remain the same, whether it's a open surgery or whether it is a kind of a laparoscopic surgery. You basically have to put an incision on the white line of told. Okay, so you incise the white line of told and you start mobilizing the colon. Okay, you reflect the colon medially to expose the Gerota's fascia. So you start mobilizing the colon and reflect it medially in order to expose the Gerota's fascia. On the right side, mobilize the hepatic flexure and reflect the duodenum medially through the Cocker's manual. On the right side, hepatic flexure and kind of the duodenum also has to be mobilized because with the Cocker's manner because you want to reach to the kidney. On the left side, you mobilize the splenic flexure and the spleen medially. Okay, so you don't mobilize the entire spleen medially.